If you compare 1990 with today, you will say that the number of people that die and the proportion of people that die have very much decreased. Our population has increased, the number of people that die have decreased. And those gains have been done in the places where it is easier to do things. But if you read the Lancet articles and a number of articles that were published at the beginning of this year, you will read that today 60% of maternal mortality, 53% of infant mortality, 44% of neonatal mortality. The mortality due for the compensation of chronic non-communicable diseases due to interruption of treatment occurs in the protracted crisis, occurs in the fragile and vulnerable context where acute emergencies are recurrent. So somehow, if we want to have a marginal gain in the different areas where we work, the place where this happens is in DRC, in Central African Republic, in Pakistan, in the places where there are protracted crises, where there is conflict, and where there is recurring acute events. So people in emergencies die usually by a bundle of diseases, not by one. Even in epidemics, not by the main causes of epidemics. I would say that there are 18, but let's talk first of all of what is an emergencies and what type of emergencies there is, and why do they occur, and how come this type of deaths occur. So, emergencies is when there is a mortality, morbidity, discapacity, and suffering that is above average. It's something that appears, that increases. And if you think about it very strong, you might be able to list 100 causes of emergencies, but this will be an academic exercise, and we are practical people. So in practical terms, what are the emergencies? The big ones are, let's go from the fastest to the slowest. When there is an earthquake. Earthquake is a geophysical movement. There is also volcanoes, there is also landslides, but this is the movement of the soil. And what happens is that the buildings are destroyed, the water systems are cut, and this would lead to certain patterns of disease. And another emergency that is really acute also is the technological. It can be nuclear, like in Fukushima. It can be toxic. It's really fast, and while they can be very diverse, including, for example, the use of chemical or toxic things in warfare, what you want is to take people away from the source of the mortality. So they have that in common. Then there is another one that is quite fast, but not as fast. Thanks to technology. And it will be when there is water and wind, the hydrometeorological, especially water. And they are not as earthquakes because with today's technology we see them coming. We know that in 48 hours, Matthew is going to arrive to Haiti. Therefore, there is time to take people away. And usually the mortality of people the mortality is lower, but the destruction is high, and people do not have a place to arrive. Therefore, you will find the diseases that are spread by water, but also having lost their homes, people will be on high concentrations in special places where they gather. So the transmission of diseases are easier. So that leads to another pattern. So we have 3 of them now. Then we become a bit slower. Outbreaks is an interesting one because outbreaks may occur instantly, but they are detected through time. So you know that the number of cases of something that is killing people is increasing, but you don't really know what it is. So you do an investigation, you take samples, you know the number of cases, you make differential diagnosis. So it will take time to make sure that there is an epidemic of Rift Valley fever. And to understand what Rift Valley fever is, what are the consequences for people. And that will be outbreaks is part of what we call biological types of emergencies. Of course, there is many more, grasshoppers, for example, but epidemics is the big one. Then warfare represents part of what is social conflicts. That is also a large group of possibilities, but in war also, the clarity that there is a war is not instantaneous, because this is a shift from politics to warfare that goes through different events until it's evident for everybody that is. And it is rarely very fast on appearing and disappearing. It can happen. In Nagorno-Karabakh, this happened a few months ago, but usually it's quite long, and war is the biggest cause of mortality, and mortality does not occur because of the wounds. But you will see there are many, when there is war, there is destruction of health system, there is people that lose their homes, there is more outbreaks. Outbreaks is a big killer on this one. And the last one is the slowest one, is the slow protracted climatic drought, and many others. And this last one is becoming more and more common. So what happens in these 6 types of emergencies? There are like 11 different risk factors that have been described in a ODI publication by Michel Gaillet, Francesco Checchi, like loss of the shelter, breakout of the water services, lack of access to treatment, etc. They will bundle in different ways, and they will lead to a number of diseases that will lead to a number of interventions. So when you think about it, if you know the cause of the emergency, if you have an idea of the severity and the magnitude, if you can talk with somebody that already knows the country and knows the capacity, you can already do a lot of things without having the numbers. You know what to put in an airplane. You know who to send, because you know it's an earthquake, and in earthquake all the life saving is going to be done in the first 3 days. And there will be like a month to work on rehabilitation, physical rehabilitation. And then there is the reconstruction of the health system. So you know a lot before you have already the precise data. So what are the diseases that increase? There are 3 that will increase almost always. They are diarrhea, respiratory infection, and neonatal and maternal mortality. This is the bulk of mortality in almost all emergencies. And also when you treat a disease, there are the possibilities to treat it on the health system or outside in the community. The problem when you have to treat something in the health system, like for example, maternal mortality, is that you cannot really scale up health facilities and health staff very fast. So there are limitations of what you can do. It takes more time. Whereas diarrhea, for example, is something that you can handle at community level, because you know that people actually don't die of diarrhea, they die of the dehydration. So probably by a very early detection of cases and early hydration, people will not die of diarrhea. That is a relatively easy one. And in order to produce this hydration, you can have oral rehydration salts, and the relative new thing with that is that now people, I never pronounced this one well, zinc, is that well pronounced? So if you put in the ORS zinc, the survival for diarrhea, respiratory infections, and other diseases increases. It's a very protective element. So by setting early detection, you can do a lot for diarrhea. Now, know that the diarrhea, the most frequent cause of diarrhea is rotavirus. So when we talk about vaccines, we're going to find something quite interesting, is that there are some places like in Somalia where you will have a very random access to populations. You don't know when you can go, you don't know when you can return. So you might want to take advantage when you go to do things that can help people for the longer term. So vaccination with rotavirus can be something great. Yeah? Among the respiratory infections, the ones that kill are the bacterial one, the pneumonia. And here also we have a vaccine, the vaccine for pneumococcus. But for pneumonia, the thing is that the most important cause of mortality is the bacterial one, and there is a treatment which is antibiotics, and essentially amoxicillin with clavulanic acid. Nevertheless, we have the problem of the resistance. So in respiratory infections, we are a bit in conflict, because by one side, by providing antibiotics early in respiratory infection, pneumonia, you will save people, but by giving antibiotics of people that do not really need it, you are spreading the antimicrobial resistance. The third one, an important one, is maternal and neonatal mortality, and they come together because they occur in the same window and they come as a package, but they are different. Mothers die for several reasons, but big one will be by bleeding. And there can be also hypertension linked to the pregnancy, but bleeding is the big one. And in order to manage this, you need a contact with health facilities. So there are two countries that did an incredible improvement in maternal mortality: Rwanda and Cambodia. And the way they did that is that before there was 25 to 30% of the deliveries that were attended in health facilities, and today for both countries is 90%. So this is the main thing to help mothers survive. Whereas if you think it in the long term, the most important factor in maternal mortality in the long term is women education. Every year at school, every additional year at school leads to a better survival of mothers. And children, you know, the biggest mortality in life occurs in the first 5 years, but most of them occurs in the first year, and most of them occurs in the first month, and most of those in the first week and in the first day. So this is the closest you are to birth, the bigger the risk of mortality. So of course there is nothing better for protection than maternal milk, but if you are too weak to suck, then being helped with a spoon to eat is going to help you fight against hypoglycemia. Force and help the babies to eat until they are strong enough to do it by themselves. And then there is hypothermia. And hypothermia, you must all be familiar with the kangaroo type of things in which babies are put very near the human body to be able. So you can tackle most of the causes of mortality with simple measures and improve the survival of the 3 highest killers. And then there are 3 others that are very common, but they have each one a particularity. For example, malaria, you will find it only in the tropics. So you will not find malaria in Siberia, but it's a huge cause of mortality. Another one in which you don't, and for malaria, what can we do? We can do marvelous things with malaria, for malaria, with 3 things that have very short names. They are called ACT, RDT, and LLIN. RDT, let's start by RDT. RDT is rapid diagnostic test. And they are important for 2 reasons. Number one, because you know that it's malaria, and you can give the treatment, but you know that it is not malaria, or it might not be, so you will not feel satisfied enough by providing anti-malarials. You're going to search if there is something else, an infection of the ear or another case, so you might be able to detect and treat another cause of fever. If you decide to treat, the best medicine that we use now is called ACT, which is artemisinin-based combination therapy. Combination is really important because, as we know, malaria has been able to produce resistance to medicine, so you give it in combination to make it more effective, but also to fight against resistance. And what happened with ACT is that once you get the medicine in your body, it can decrease the density of the parasite from 10,000 to 1 in 1 hour. So people that were going to die of cerebral malaria because their blood cells were totally deformed by the parasite, which was going to clog their brain and other parts of their body, are going to see a big decrease on the number of parasites. When you give a treatment for malaria with Fansidar, with other medicines, it's going to produce gametocytes. So the malaria will disappear, but the gametocytes that might become now resistant to the medicine are in the blood. And when a mosquito sucks it, it gets the gametocyte. ACT destroys the gametocyte. So it's not only a protection for the person that is sick, but the protection for the person that can get contaminated also. And the last one is long-lasting impregnated nets. So you know that if you put a mosquito net, you are not going to be bitten by a mosquito. But if you have used a mosquito nets, you might know that if there is a hole, you can get a mosquito inside that will bite you and has no way to go out. So some of the people that make the mosquito nets put insecticide and protecting factors against ultraviolet light and migration inside the substance that they use, the material they use to do the mosquito nets. And when it's done, the insecticide that is inside will be released very slowly in extremely low quantities for the next 5 years. So probably the capacity of the mosquito nets to destroy mosquitoes will be longer than the life of the mosquito net itself. And by using this type of mosquito nets, you have a double effect. This type of materials has been used, for example, also for blankets and for tents, so there is a lot to explore. So malaria mortality can be very much decreased. The other one for which people don't think very much is tuberculosis. Tuberculosis is such a big killer, and it's linked to poor resource settings. So malaria with tropics and tuberculosis with poor resource settings. And you don't think about it because it's like a slow, long-term disease, and the treatment is very, very, very long. If you put in a basket all the medicine that you need to treat one case of tuberculosis, it's going to be huge. There are advances on tuberculosis, and treatments are becoming shorter, but when I say shorter, I mean 9 months instead of 24, so it's still very long. And another big improvement on tuberculosis that appear thanks to HIV treatment is that the typical diagnosis of tuberculosis was by looking at a slide with sputum. Now we can do it with machines that are like GenExpert that will be able to very rapidly confirm that there is tuberculosis, but will also give you an idea if the tuberculosis is resistant to a particular medicine. So it gives you the pattern. So GenX, which come in different prices and different sizes, is becoming the standard even in poor resource settings. And the last big one would be trauma. And trauma is common on conflict and on natural disasters, earthquakes in particular, but also it's related to floods. And the thing with trauma is that you have to manage the trauma, but trauma can also lead to physical disabilities. That is also something to take care of, and I will talk in that in a minute. Trauma is also difficult to improve in terms of survival because the main thing is to get the person that is affected by the trauma to a health facility. It's also very linked to a health facility. So the transport systems is a big issue here. Now, one of the reasons, ICRC, you know, ICRC is the Red Cross. The Red Cross is the main organization that works on protection in conflict. And in order to work in protection in conflict, they use the different modalities of aid to crystallize protection, because protection is kind of an empty concept until it's crystallized by a particular assistance action. So they want to be close to the combatants in order to be able to provide the role in protection. And one way to be close to combatants is to offer them first aid training, which allow them at the same time to be able to teach how to help people that is wounded to survive and try to set up reference systems, but at the same time to be in contact and have a presence that helps to create an environment of protection. Those are the 6 main causes of mortality, but maybe they are less important than other 3 things that rarely kill, but that makes everything else be worse in terms of number of cases of diseases and mortality. I call them the accelerators. And they accelerate other diseases because when you get them, the immunity of the body will decrease. Therefore, you are more susceptible to get sick and to die of the disease. One of them is malnutrition. Malnutrition comes in 3 flavors. You eat too much, and believe me, this is an each time more frequent element that you will find in some of the conflicts where we are. You can find it in Middle East in particular, for example. People can be overweight that will lead to metabolic diseases, and the main causes of mortalities in those crises may be chronic non-communicable diseases and not the communicable diseases. Then there is the malnutrition due to lack of food and the malnutrition due to lack of specific micronutrients. And the one of lack of food comes also in 2 varieties, the one in which you lose a lot of weight for your height, so this is called the acute one, and it's linked with an immediate increase of acute mortality. And there is the one where you keep being malnourished through a long time, and then you lose height for your age, and that's called the chronic malnutrition. And both are important. The acute malnutrition because it produces acute mortality, and it's the most important for me, but the chronic one will affect the capacity of the new generation to learn. So for malnutrition, what you can do is to provide food, of course. And when I started to work, food was provided for malnourished children in nutritional centers. And like witches, we prepared what they had to eat, and it was done with dry skimmed milk that was enriched with sugar, with multivitamins, and with fat that was at that time dehydrated butter. And we did this and we had like 1 calorie per milliliter, and according to the weight of the infant, we can calculate the food we gave. After that, we invented the same thing, but already per package. It was called F700 and F75, but today we use something quite different that is done with plum peanut, multivitamins, and dry skimmed milk and other things. It comes in a package that is just to open, so it's called ready-to-use therapeutic food or ready-to-use supplementary food. And the big difference is that when I started, this was done in therapeutic centers. Now we don't need the mothers to abandon the other children to come with these sick children, and the other ones can become sick. You can distribute the RUTFs at the community level, increasing the coverage. So plum peanut is such a great example of an intervention that you are able to scale up. Because one of the problems of health compared with other types of assistance is that it's very difficult to scale up because of the need of facilities and trained health staff. Plum peanut is one example where you didn't need to do this type of things. The other one is HIV. HIV will produce the same thing, and HIV is one of those areas like malaria that have had well-known big developments. So there is a huge difference today on what we can do for HIV. There are cocktails of medicines that are ready to use, treatments are shorter, etc. Diagnosis is easier, and those are the ones that are benefiting, for example, the diagnosis and treatment of tuberculosis. So we have a lot of advances on that one. And the last one is measles, because measles, that also rarely kills, produces also a decrease on immunity, and know that sometimes they come together. In Maiduguri, in northeastern Nigeria, we have malnutrition and measles. Bad combination, because together they are going to be responsible of these 4 per 10,000 per day of mortality, and of those 4 to 23% of severe acute malnutrition, which are skyrocketing biblical levels of malnutrition. Okay, so the thing is that one of the first actions that we do today in any emergency is to vaccinate against measles. And measles have to be, and we have seen that not only this is great for measles, but when you vaccinate against measles, like a number of other diseases decrease. Even if you don't see cases of measles, measles vaccination may have an impact because they decrease immunity and they have an impact on other diseases, even if it's subclinical. I will divide outbreaks in 4 groups. Number 1, the big unknown, the next Ebola, the next MERS, the next SARS. We don't know what is coming, but we need to be prepared for it. The second group will be the most important for me, is the usual ones. And the usual ones are important because they are the most common causes of epidemics in the emergency situations for which we can do something, but they are also preparing us to fight against the big unknown one. And they have all the possible mechanisms of transmission that you can imagine. They are measles, as I have told. Then there is yellow fever. Then there is cholera. Then you have the viral hemorrhagic fevers. And then you have meningitis. So you have transmission by air, transmission through vectors, transmission to body fluids, transmission, oral fecal transmission. So by having effective responses against these 5 epidemics, you will be prepared to have an effective response to the big unknowns, whatever it comes. The one that is transmitted by air is the meningitis by Neisseria. If I took a swab of our noses here, 1 of every 3 of us will have meningococcus in the nose. But this meningococcus that is there is living a happy life in a very humid and comfortable environment. But if you were living in the Sahel, things will be very dry, so you don't see any more your transpiration. When you transpire, it will evaporate immediately. And the nose gets very dry. And you know that what eats over the nose is the brain. So when the nose area becomes dry, it becomes unhappy. That's called virulence. And it can go to the... So when the conditions are ripe, we can have meningitis. And meningitis is a bit like the fire. It occurs during the dry season and it follows the wind. So vaccination can be done as in a fire. You vaccinate in the places where meningitis is happening and in the places where meningitis are likely to spread. For cholera, as I told you, it's a type of diarrhea, so early detection and hydration is key to improve the survival. And for the severe cases, what you need is to give a lot of liquids. People get scared when you pump inside the body so many liters, but remember that cholera is a toxin produced by the vibrio that is going to stick to the walls of the intestine, and it's going to inverse the sodium potassium pump, and instead of putting water inside the body, it's taking water outside the body. There is something called the dry cholera, where people will die without ever having diarrhea because all the liquids are inside the guts. So it's a very powerful mechanism, and therefore a lot of hydration will save people. Meningitis, cholera, yellow fever, vaccination, mosquito. Okay? And that would be the second group. There is a third group that I call those that are limited geographically. So these are the ones for which we have made the EPI, the typhoid and all these diseases. They can occur as small outbreaks, but it will not be a risk of spreading internationally. And the last ones are those that are very difficult to fight because they are linked with the environment. And dengue, Zika, chikungunya, all those are related to this very difficult area of linked to the environment and to social and geographical constraints. Then you will have the physical and mental disabilities. The physical is because there was trauma and there are things to be done. And the important messages here is that when you do physical rehabilitation, it is something that you cannot imagine to do for 15 days. If you are beginning to do physical rehabilitation after an earthquake in Haiti, think on 2 years. Because people will need surgery, will need prostheses, will need replacement of the prostheses, will need education, so this is something for the long term. And mental health, all the causes of, all the main elements of mental health and psychosocial conditions in average double in conflict and protracted emergencies. So you will have big levels of this. And the thing with mental health is that everybody agrees with the concept that we should not treat only the extreme cases. Mental health should be something that we should address at the level of communities in order to avoid those individual cases, but people have not really found before the way of doing it at the level of primary health. Until some of our colleagues here and other people like outside, but Marva Nomeren in particular, they came with something called the MH gap, the mental health gap. And there is a special edition for emergencies, and it goes through a number of diseases and conditions, and it has 2 levels, the one that is like for everybody and the ones that are for doctors and people that use medicine, specific drugs to treat things. And the thing with this particular publication is that when you read it, may you be a nurse, a doctor, a midwife, etc., you read it and you say to yourself, I can do this. It's really well explained on how can you address mental health and psychological conditions at the level of primary health care. And finally, there will be those conditions that are not maybe as common, or they might be commoner, but belongs to a full other group. One of them, for example, will be chronic non-communicable diseases. Chronic non-communicable diseases, diabetes, hypertension, cardiac conditions, cancer, are becoming a leading causes of death in the world and on certain or in certain emergencies, Middle East in particular. But as demographic shifts begins to occur everywhere, there are some countries in Africa where in the emergencies, the main cause of death might be chronic non-communicable diseases. And why do people die of this? Because they had access. I remember when I crossed the Ivory Coast War, when I crossed to the other side, and I asked the people what were their problems, I was surprised to hear the response that they cannot use anymore their social security card. So it's a different type of world. So the thing is that they don't have access to their normal treatment, and then they decompensate and they die. Now, there is something particular that is very much in fashion and that works for many things, but not for health. It's called now cash transfers. Everything in humanitarian aid is now cash transfer. So you don't give any more this or that, you give cash and people buy, right? Now, people buy things that are a recurrent expenditure. And health is particular that if it's not something severe and you don't make the expenditure, you keep the money in your pocket. And if you're sick, what you're getting is not enough because it's a great expenditure. So cash is not a great element for this. But chronic non-communicable diseases is something for which people will use cash because they can forecast a regular expenditure. So maybe the solution for the future that can be done in some places like Iran, like in Ghana, like in Costa Rica, is that what UNHCR does is that, for example, Afghan refugees in Iran, they can work. When they work, the employer has to pay for them insurance. If they don't work, UNHCR will subsidize the insurance for them. And they have access through a regular expenditure to whatever happens. So this is a way to use the cash transfer. And in terms of survivals of mothers and children, there are no magical formulas, and cash transfer is not the great solution, but vouchers may be. Because if people know that the full payment of a delivery with antenatal care is 3,000 euros, but I sell you for 70 euros the full treatment, you see it as a good investment. And once you have paid the 70 euros for your voucher for antenatal care and delivery, you will have the antenatal care. And by doing the antenatal care, you will detect the increase on the blood pressure, and you will make sure that people go to a health facility for the liver, and therefore there is survival. So in chronic non-communicable diseases, this can be a way forward. And also for most of emergency, we have something called emergency kits. And essentially, we put in an airplane packages of medicine that are able to provide medicine and treatment for 10,000 people for 3 months of the most common diseases. And by its side, there is a malaria kit in order to treat also malaria. But this year, thanks of a work of one of our colleagues called Slim Slama, we are having for $25,000 the kit for chronic non-communicable diseases for 3 months to send to Yemen. The other one is neglected tropical diseases, which last year were 17 and now they are 18. And chronic non-communicable diseases are rare. They are not most of the causes of mortality and morbidity, but they tend to occur in places where where protracted and acute emergency occurs. And finally, there is vaccination. And of course, when we say vaccination, you think on EPI, and you think on measles, of course, in every emergency, and now you begin to think on pneumococcus and rotavirus, but know that there are 24, yes, antigens that you could use. So there is a recently published book called Vaccination in Humanitarian Emergencies that tries to give you the elements to think out of the box of what would you do in Somalia if you have a very random access to a population using vaccination to prevent things that you will not be able to treat because you cannot have a sustained presence there. So the last point will be the link with health systems. Because if you think about it, an emergency operations for health is a bit like a war operation, meaning that the troops advance, and in order to advance and win the war against a disease, you need the bullets and the food and the sleeping facilities behind. So in emergency operations where an NGO arrives to help in a very difficult circumstances for people to survive, is they appear with supplies, with finance, with people, and go ahead. But if you do this in Central African Republic, you will see that whoever leaves any district, the departure will be associated to an increase of mortality that might very well go beyond emergency thresholds. We have already measured that. So the substitutive approach is a great thing to do when there is an acute excess mortality that appears. But if this is going to last on time, you have an interest to try to fortify and strengthen the system and the pillars of the health system, the human resources, the capacitation, the construction and rehabilitation of health facilities, the information systems, the training of staff for the future. So, questions?
How do you decide when something is an emergency and when it's over, and kind of how long to keep going, and how do you prioritize? I guess this must be many emergencies going on at the same time.
You know when the levels of mortality and morbidity increase, or you know that there is a high level to increase if you don't do anything. So this is the 6 scenarios that I gave you. So you have the scenario, and you put on your equation the severity, the magnitude, and the local capacities, and that makes you make the decision. Now, in the response, there are going to be 2 phases, the scale up and the continuation. So I manage now 3 emergencies, now 2. So northeastern Nigeria, Borno, Rift Valley fever. So as long as you are on the scale-up phase, you need to do a lot to increase. But then this is when you have to begin to work with your colleagues in health system strengthening, because some of them will stop, but most of them will continue and will need a long term. So it goes out of the emergency realm of a scale-up, but it needs a continuation.
I would like to ask, say, for example, cholera, and say WHO and other collaborative partners have been doing a lot of work in Africa for prevention and control of the cholera. I'm still wondering why the cholera cases still keep ongoing, and what are the challenges, and what do you think about is the local factors that hinder the relief work or the containments or control measures in these areas?
So, cholera. In the last year in Africa, there were 108 cholera alerts. And there are today like 18 countries where there are cholera outbreaks ongoing. They include Americas, Haiti in particular. They include Middle East, Somalia and Yemen. They include East Africa, Ethiopia, Tanzania, Kenya. So there are many places where cholera happens. The case of Haiti has to do with a magic number that's called R, the reproductive ratio. If you're an epidemiologist, you know that R is going to be your target. If R is higher than 1, the outbreak is going to increase. If R is lower than 1, it's going to disappear. If R is 1, it's going to be there forever and it's going to become endemic. Okay? So what happened in Haiti is like a fire, because R depends on the number of contacts you have, the period of transmission of a number of factors, but the main one is the immunity of the population. So Haiti was a place where a dense population in not great conditions, sanitary conditions of water, and etc. I have to say something about water. That's a great introduction. And cholera arrived in a place where there was zero immunity. So the R was the maximum R possible, and it just spread like fire. And what you have to do at that moment is to detect and treat the cases. But what you should do in the long term is to produce a better environment and water and sanitation conditions. So why is our level of health in Geneva different than the one you can find in southern Malawi? The responses are just outside that door. If you go to the left, there is a bathroom, and if you go straight forward, there is a cafeteria. And in the cafeteria, they don't sell any more sugar. They sell fruits, they sell Swiss cereals with yogurt, salads, sushi, good food. And if you enter on the bathroom, you find the 3 main things that respond to your question. There is a toilet, there is clean running water that is without any limit, and there is soap. Yeah? So there are some outbreaks that are particularly important because they appear suddenly in places where they have never been before. So we have to go really fast. And that will be Iraq, Yemen. We have to do that because chances are that we control it and it disappears. And there are the places where the level of poverty, development, environmental, water, running water is such that the outbreak keeps perpetuating. You know how many cases of cholera we register on Democratic Republic of Congo every year? Around 20,000 year after year. And around, I would say that gives you the elements of response, the susceptibility of the population, the particular circumstances that make it exceptional and a very fast, strong reaction, and the overall environment. Of course, you know there is a vaccine, and a vaccine can be as helpful as it is dangerous, because when you're vaccinated, you feel like you're Superman and immune. Vaccine is something that can help a lot, but in the case of cholera, it's one element among many, and cases still have to be detected, treated, and particularly the water, hygiene, and sanitary conditions have to be improved. Other questions? We have a few minutes left.
I have a question about the sustainability approach when we talk about rebuilding health systems, because that requires a lot of commitment in terms of time and resources. So how do you get people committed and invested in?
Okay, the thing is that we usually think on health and work with the Ministry of Health. But you know who really calls the shots in a government is the Ministry of Finance and the Ministry of Planning. So what we need is to be able to talk with these people. Now, I think Ebola was a game changer, because before Ebola, people didn't think that it was so important to invest on health. You really prefer to invest in roads or in agriculture. But Ebola showed that if you blink, if you close your eyes to health, you can have dramatic economic consequences. So I guess that particularly in these environments that are the big challenges, the protracted crisis, the last mile, the example of Ebola can help you to negotiate and argue with the governments, with the Ministry of Finance and the Ministry of Planning, that investing in health is a great investment. Thank you very much.